Welcome to this video on chronic obstructive pulmonary disease aka COPD. I am Shahinsha K V, tutor cum physician associate from Department of Physician Associate, Yenepoya School of Allied Health Sciences, Yenepoya deemed to be university. At the end of this session about COPD, the audience will be able to define what is COPD, list the risk factors and causes of COPD, explain the pathophysiology, signs and symptoms, also to describe the investigation and management of COPD as well. First of all, we will learn about what is COPD. Chronic obstructive pulmonary disease is defined as a disease state characterized by airflow limitation that is not fully reversible. COPD, it is nothing but a progressive lung condition that causes into breathing difficulties, also airway obstruction. It includes two main conditions called emphysema, which means alveolar destruction, and bronchitis, which means the inflammation of bronchial tube. We will discuss about these two conditions in detail in next few slides. So here you can see a diagram where you can differentiate a healthy bronchial tube and a healthy alveoli from an infected bronchial tube and a collapsed alveoli. You can see how clear is the passage in a healthy bronchial tube comparing to a infected bronchial tube where there is mucus production and it is already inflamed, leading to a narrowed passage. Then in coming on to alveoli, it is very definite in shape, while comparing to collapsed alveoli, it is very indefinite in shape because the walls of the alveoli got damaged or destructed. Asthma would be correlating with these two conditions in a way that asthma is a reversible condition, but if it is left untreated, it can lead to or progress into a COPD condition. Coming on to chronic bronchitis in detail. Chronic bronchitis is an inflammation of the lining of the bronchial tubes which carry air to and from the air sacs, which called alveoli of the lungs, which means you all know bronchial tubes carry air to and from the air sacs. Due to any habitual actions like tobacco smoking, constant exposure to air pollution, that can lead to bronchial tube irritation, which can finally cause inflammation, which means bronchitis. It is characterized by persistent cough and mucus production. Then emphysema. Emphysema is a condition in which the alveoli at the end of the smallest air passages of the lungs are destroyed as a result of damaging exposure to cigarette smoke and other irritating gases and particulate. Due to constant exposure to any harmful gases or chemical fumes or tobacco smoking, our alveoli, specifically the walls of alveoli, would get damaged. Alveoli are the tiniest air sacs present in our lung tissue where there would be gas exchange taking place that would impair the breathing. This is how an infected or collapsed alveoli and a healthy alveoli would look like. You can see the walls in a collapsed alveoli got destructed by the factors which we discussed in earlier slide. Coming on to risk factors. Patient who are diagnosed with asthma, patient who are in a constant exposure to pollution, also smoking, those who are over the age of 14 years, then chemical exposure, alpha-1 antitrypsin deficiency, then chronic bronchitis. Now coming on to pathophysiology. Due to habitual conditions like tobacco smoke, constant exposure to air pollution, our bronchial structures would get irritated. That can finally lead to inflammation, which means chronic bronchitis, where there will be swelling on bronchial tube, secretion of mucus, persistent cough, and bronchospasm. COPD can also be caused due to alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin, which maintains the lung architecture by preventing the breakdown of our elastin. Elastin means a protein which maintains the elasticity of our lung tissue. So people with alpha 1 antitrypsin deficiency will get breakdown their elastin, which can finally lead to emphysema. Emphysema means destruction of alveolar walls, which causing an airway instability. These two conditions, chronic bronchitis and emphysema, will cause airway obstruction, air trapping, dyspnea, and frequent infection, which can finally lead to abnormal ventilation perfusion ratio, which means the air reaching and the blood reaching the alveola would not be same. This mismatch would cause an inefficient gas exchange in alveola, also hypoxemia, also hypoventilation, which means inadequate breathing to maintain the oxygen demand. Then cor pulmonale. Cor pulmonale means right-sided heart failure due to chronic lung condition that causes an increased pressure in pulmonary arteries that will make our right ventricle to work harder, which eventually fails. Coming on to the general symptoms a COPD patient would experience: mild but persistent cough, breathlessness, which can progress into an increased breathlessness, chronic cough, wheezing and chest tightness, also fatigue. Now we will see how a severe COPD patient would look like in appearance. They would be easily fatigued, frequent respiratory infections, use of accessory muscles to breathe. Also the patient would be orthopenic, which means they would feel difficulty in breathing while lying flat. Cor pulmonale, which we discussed earlier in our pathophysiology slide. Then thin in appearance, wheezing, pursed lip breathing, which means patient would exhale through their mouth. Then chronic cough, barrel chest, their chest would be looking like a barrel instead of being flat. Then dyspnea, prolonged expiratory time, bronchitis, increased sputum, also fingertips would be bulged, which means digital clubbing. Coming on to diagnostic evaluations: medical history, spirometry, chest x-ray, CT scan, laboratory test, which includes arterial blood gas analysis. First, we have to get a brief history on whether the patient recently had a cold or flu, whether the patient smoke or spend time around others who smoke, whether the patient exposed to dust, fumes or air pollution kind of things. Coming on to spirometry, it is the most common pulmonary function test. Patient breathe into a large flexible tube that is connected to a machine called spirometer that will measure how much air the patient's lungs can hold and how fast the patient can blow air out of them. Chest X-ray, it supports the diagnosis by showing the lung damage. CT scan will use several X-rays to create a detailed picture of the patient's lungs. Then arterial blood gas test, it measures how well the patient's lungs are bringing in oxygen and taking out carbon dioxide. Coming on to complications, these includes respiratory infections, heart problems, lung cancer, high blood pressure in lung arteries, and patient would feel depression. Coming on to management, persons with COPD must stop smoking. This is the best way to slow down the lung damage. The appropriate medications for COPD depend on its stage of severity determined by symptoms. Moving on to pharmacological management, bronchodilators, corticosteroids, anticholinergic, xanthine derivatives. Main objective of these 4 drug groups are to open up airways and improve the breathing. Bronchodilators are the first line treatment we give for a COPD patient, that includes salbutamol, albuterol, formoterol. Then corticosteroids are given to reduce inflammation for those who are in a severe to moderate. We are moving on to pharmacological management. Bronchodilators, corticosteroids, anticholinergic, xanthine derivatives. Main objective of these 4 drug groups are to open up the airways and improve the breathing. Bronchodilators are given as a first line treatment for COPD, which includes salbutamol, albuterol, and formoterol. Corticosteroids are given to reduce inflammation, which includes betamethasone, prednisolone, and metaprednisolone. Then anticholinergic, atropine sulfate, xanthine derivatives, theophylline, and aminophylline. When a patient no longer responds to medications, surgery becomes a viable option. In rare cases, surgery may benefit some people who have COPD. Surgeries include bulectomy, lung transplantation, lung volume reduction surgery. Let's see what is bulectomy. When the walls of the air sacs are destroyed, larger air spaces called bullae form. These air spaces can become so large that they interfere with breathing or they directly impact in breathing. In a bulectomy, one or more very large bullae from the lungs will be removed. Lung transplantation. A lung transplant may benefit some people who have very severe COPD. During a lung transplant, damaged lung is removed and replaced with a healthy lung from a deceased donor. In lung volume reduction surgery, surgeons remove damaged tissue from the lungs. This helps the lung to work better. Finally, we are coming on to the general management strategies which patient can incorporate into their lifestyle based on their stages currently which they are in. In stage 1, patient can increase movement by walking, biking, etc. Eat a nutrient-rich diet. Avoid triggers like mold, dust, perfume, etc. For a stage 2 patient, we would recommend the patient to join a smoking cessation program, attend peer support groups, focus on managing the symptoms. In stage 3, we will ask the patient to start pulmonary rehabilitation program, practice breathing exercise, stay as active as possible despite the symptoms. In stage 4, we will ask the patient to quit smoking, including e-cigarettes, continue management strategies as designated in stage 3, see healthcare provided regularly. Coming on to the summary. So COPD includes chronic bronchitis and emphysema where the airways become inflamed and damaged. Common symptoms are shortness of breath, persistent cough and wheezing. Investigations includes history taking, chest x-ray, CT, spirometry and ABG analysis. COPD has no cure, but it can be managed with medications, lifestyle changes, oxygen therapy and pulmonary rehabilitation. These are my references in Vancouver style. Thank you.